Good evening, everyone. Welcome to this free webinar. Of course, I'm so glad to have you with us today. It's our pleasure as the mid-exam team to offer some free webinars for our colleagues who are preparing, inshallah, for the MRCOG Part 1 exam. Inshallah, today we are going to talk about endometrial hyperplasia, the points related to its pathology, and of course, the outlines of management according to the British guidelines. Before we start our session, of course, the last few exams in the MRCOG Part 1, the percentage of the clinical questions have increased. So we have to know some basic guidelines, some things related to the clinical management issues, not only the basic science we used to know for the MRCOG Part 1. Yes, we have to study anatomy, physiology, biochemistry, microbiology, and so on, but also we have to know some basic points related to different topics of the clinical management. So that's why we are going to give some sessions about these topics. We already have started the last week by the polycystic ovary syndrome, which was given by my partner in MRCOG Part 1 course, Dr. Zaid. And today, inshallah, we are going to study or illustrate the endometrial hyperplasia, and there will be also more sessions coming about other clinical topics. But of course, I know that the first question will come to your minds: do we have to study all guidelines for MRCOG Part 1 exam? My answer is still no. Of course, we are not going to study all the guidelines for MRCOG Part 1 exam. Okay, this is the main syllabus of Part 2 and of course Part 3. But for Part 1, we have to know some basic concepts from few guidelines. Some important topics, some very common topics in gynae and obstetrics we have to know, and of course we have to know how to manage them. So of course we are not going to study all the guidelines. Of course we are going to give a hint about the most important guidelines to be studied for MRCOG Part 1, and even we are going to summarize and highlight the most important points within these guidelines. So in this session, we are going to have a quick introduction about endometrial hyperplasia and its epidemiology. We are going to address the risk factors and the etiological factors. Also, we are going to talk about the classification and the pathological types, and also how to diagnose, and the last point, how to manage the different types of endometrial hyperplasia, including some special considerations. Of course, our main reference for this topic is the Green Top Guideline number 67, Management of Endometrial Hyperplasia. Before we go through the main points of our session today, MedExam is offering a gift at the end of this session. So after I'm finished, one of my colleagues in MedExam, the course coordinator and the IT specialist, will talk to you and offer you this gift, inshallah. But this is, of course, at the end of this webinar. Endometrial hyperplasia is defined as irregular proliferation of the endometrial glands with an increase in the gland to stroma ratio when compared with the proliferative endometrium. So this is the cornerstone point, how to differentiate the endometrial hyperplasia from the normal proliferative endometrium, which is found in the proliferative phase of the endometrial cycle or the uterine cycle or the menstrual cycle. This is the point, the increase in the gland to stroma ratio, the increase in the gland to stroma ratio. The glands are increased with little intervening stroma in between these glands. So this is the hallmark of differentiation between the endometrial hyperplasia and the normal proliferative endometrium. Of course, the most common presentation of endometrial hyperplasia is abnormal uterine bleeding. And of course, in its different forms, maybe the presentation is heavy menstrual bleeding, or maybe intermenstrual bleeding, or irregular bleeding, or even unscheduled bleeding on hormone replacement therapy. Those women who are taking hormone replacement therapy may experience unscheduled bleeding while taking the hormone replacement therapy. So this is a very important and alarming point, and also could be presented as post-menopausal bleeding. So that's the main presentation, abnormal uterine bleeding of different forms. The overall incidence of endometrial hyperplasia is about 133 per 100,000 women. And the peak incidence is between the age 50 and 54 years. So this is the peak age of endometrial hyperplasia, between 50 years and 54 years of age. Why we have to focus on endometrial hyperplasia, or why we should care about this problem? Because of course it's the main precursor of the endometrial cancer, which is the most common gynecological malignancy, and it's the 6th most common cancer for females and the 14th most common cancer overall. But for the gynecological malignancy, it's the most common. And of course, because of the increased incidence of its risk factors, which will be addressed in the coming point, the endometrial cancer incidence is increased. So we have to manage these cases of endometrial hyperplasia very carefully and very early to avoid the progress into endometrial cancer. The incidence of endometrial hyperplasia is about 3 times higher than endometrial cancer. And of course, if left untreated, it can progress to cancer. And that's a very good point regarding the uterine cancer, because endometrial cancer, or the precursor of endometrial cancer, which is endometrial hyperplasia, can be presented early in the woman by, as mentioned, abnormal uterine bleeding. So when a woman experience abnormal uterine bleeding and seek for investigations, this condition could be detected early, and of course, if treated early, the prognosis will be so good. Unlike the ovarian cancer, for example, which always is presented at later stages because it's, clinical pictures is usually vague manifestations, could be silent even. So most of cases are detected late and the prognosis is worse. So worse than the endometrial cancer. But the good thing about the endometrial hyperplasia is that it's presented by abnormal uterine bleeding, which alarm the patient to seek for investigations, and that will lead to early treatment and better prognosis. Also, the progress of the endometrial cancer is very slow. So it's also a good point that most of cases of the endometrial cancer has a very good prognosis. Am I clear so far? Is everything clear?
Yes, please. Yes.
Okay, good. So what are the main risk factors or the etiological factors for endometrial hyperplasia? The main risk factor, the most important risk factor, is the prolonged estrogenic stimulation to the endometrium, especially if it is unopposed by progesterone. So the more the effect or the more the influence of the estrogen into the endometrium, the more the risk of endometrial hyperplasia, especially if this estrogenic stimulation is not opposed by progesterone. This case could be found in many situations, like increased in the body mass index. Of course, the more the peripheral fat tissue, the more the conversion of androgens in the adipose tissue to estrogen by the aromatase enzyme. Also cases of PCOS and anovulation. This also can lead to endometrial hyperplasia and of course endometrial cancer. When we talk about the risk factors of endometrial hyperplasia, it's nearly the same for endometrial cancer. And of course, I think Dr. Zeib has addressed that in the long-term consequences of the PCOS in the last webinar. So cases which suffer anovulation or PCO, these patients are at high risk of developing endometrial hyperplasia and endometrial cancer. Also, estrogen secreting ovarian tumors. The most famous of these tumors are the granulosa cell tumors. Cases of granulosa cell tumors which secrete large amounts of estrogen could be associated with endometrial hyperplasia in 40% of the cases. Also, drugs which could induce endometrial stimulation, like the estrogen replacement therapy or the hormone replacement therapy, and also the long-term use of tamoxifen, which is given as an adjuvant treatment for breast cancer, because tamoxifen has an anti-estrogenic effect on the estrogen receptors in the breast, but on the same time, it has estrogen stimulating effect or agonist effect on the endometrial receptors, leading to endometrial proliferation and hyperplasia. A Cochrane meta-analysis found that unopposed estrogen replacement therapy is associated with an increased incidence of hyperplasia at all doses. So it's not recommended for use in women with a uterus. So if a woman seeks for hormone replacement therapy, like treating the symptoms of menopause, and she has her uterus, she is not hysterectomized. So when you give hormone replacement therapy, you should give combined estrogen and progesterone. Giving estrogen alone, unopposed by progesterone, will be increased with the risk of developing endometrial hyperplasia. Other factors beside the estrogenic stimulation could be immunosuppression and infection. These are some other risk factors: immunosuppression and infection. Local infection, endometritis, may also be a cause of endometrial hyperplasia. Also, there are some genetic predisposition, some mutations in certain genes like the MIN or the KRAS gene or the PTEN gene. These are just some examples of some genes which, when mutated, could lead to developing endometrial hyperplasia. So that's why maybe the same condition in two different women, they are exposed to estrogen for the same duration with the same dose, for example, but one of them develop endometrial hyperplasia and the other not. This is maybe due to some also genetic factors which share in the pathogenesis of the endometrial hyperplasia. So these are collectively the most important risk factors related to the developing of development of endometrial hyperplasia and also endometrial cancer. Now let's talk about the classification and the pathological types of endometrial hyperplasia. Of course, there are many classifications which have developed before regarding the endometrial hyperplasia, but according to the Green Top guidelines, the revised 2014 WHO classification is recommended and adopted by the British guidelines. And it separates the endometrial hyperplasia into two main groups according to the presence or the absence of cytological atypia into hyperplasia without atypia and hyperplasia with atypia or atypical hyperplasia. And in this new classification, the complexity of architecture is no longer part of that classification. And of course, I think all of you know that before we used to classify the endometrial hyperplasia into simple and complex, and simple is subdivided into with and without, and the same for the complex is divided into simple and atypical or typical. So now the complexity, like simple or complex, is no longer part of this classification. So again, when talking about the new classification of the WHO, the complexity of architecture, like simple or complex, is not needed anymore in the classification. Also, there is a new classification, which sorry for saying new, not new, but not usually known for all of us. It's called the endometrial intraepithelial neoplasia classification. This is an alternative system which was proposed in 2003, and it's somehow used by certain, countries and some systems, like the American College of Obstetrics and Gynecology. I think they adopt this kind of classification. This classifies the endometrial abnormalities into benign endometrial hyperplasia, pre-malignant, and malignant. But this classification is not extensively used in the United Kingdom. So we have the benign endometrial hyperplasia, which is endometrial hyperplasia without atypia, the pre-malignant, which is called the endometrial intraepithelial neoplasia, the EIN. This corresponds to the atypical hyperplasia, and the last category is the malignancy. Okay, but this classification is not extensively used in the United Kingdom. And the diagnosis of EIN in the new WHO classification is considered interchangeable with atypical hyperplasia. See, this is the old WHO classification. Still some references and some books adopt this old one, simple complex without atypia and simple complex with atypia, and then carcinoma. This is the EIN, hyperplasia, EIN, and carcinoma. Some European countries also adopt this classification, hyperplasia and endometrial neoplasia. The last one, which is the WHO modified, this is the one adopted by the Green Top guidelines, hyperplasia without atypia and hyperplasia with atypia, which is considered borderline, and then the carcinoma stage. Am I clear so far?
Yes.
Yes.
Okay.
Yes, sir.
Good. So what are the main features of endometrial hyperplasia? Collectively, these features are increased in the gland stroma ratio, as mentioned before. And when we look at the glands, they have irregularities in their shape, cystic dilatation, budding and branching of these glands, villous growth, evidence of mitotic activity, but this level is variable according to the degree of atypia, and The uterus is often enlarged, slightly enlarged, and the tissues obtained when doing uterine curettage may be considerable amount of tissues. When you do a curettage to a case of endometrial hyperplasia, you could find a considerable amount of tissues while doing this procedure. Let me go through the old WHO classification. Of course, it's not important as a classification, but I'm just want to address the histology and cytology. What is the difference between simple and complex? Okay, and what is the difference between typical and atypical hyperplasia? Of course, the histology between, or the histological difference between simple and complex is according to the level of or the ratio of the gland to stroma. So the more the growth of the glands, the more the complexity of these glands, the more the gland stroma ratio. This is considered complex endometrial hyperplasia. If we look at the complex endometrial hyperplasia, the glands are so close to each other, like mentioned in this picture, okay? It's called even pack-to-pack appearance of the glands, pack-to-pack appearance of the glands. It's little or even no intervening stroma. This is the complexity of endometrial hyperplasia. And for the typical or atypical features, this is according to the cytological features or the nuclear features. When we found irregular nuclei, condensed chromatin material, prominent nuclei, increase in the mitotic activity, all these are concerning features of atypia and should be, of course, considered very carefully and very cautiously, okay? So these are warning signs. When we found these cytological changes, abnormalities in the shape and in the arrangement of the nuclei, condensed and coarse chromatin material, prominent nuclei, thickened nuclear membrane, mitotic activity, eosinophilic cytoplasm, all these are warning signs. We have to take it very carefully and cautiously, okay? And of course, the rate of progression to cancer is more with the atypical features, like we are going to mention later on. According to this according to this old classification, the progress to cancer for the simple hyperplasia without atypia is like 1% in that range. For the simple hyperplasia with atypia, 3 to 8%. For the complex hyperplasia without atypia, 3 to 9%. And for the complex hyperplasia with atypia is 20 to 30%. This is in case you find questions in some old books asking about the rate of progression to cancer. So how to diagnose and follow up cases of the endometrial hyperplasia patients? Of course, the main diagnostic modality and the cornerstone or the gold standard for diagnosing endometrial hyperplasia is the histological classification of the endometrial tissue. And this, of course, include endometrial sampling either by outpatient endometrial biopsy, like doing the people biopsy, or inpatient endometrial sampling by dilatation and curettage performed under general anesthesia. But of course, the first choice is to do a simple outpatient sampling by the people if it's not feasible or if there is indication for dilatation and curettage under general anesthesia. Of course, we will prefer that method. Like if the patient is not cooperative, for example, if she is in pain in the outpatient clinic, of course, she could not withstand the local outpatient procedure. So we may need to give her anesthesia and do classic dilatation and curettage to take our endometrial sample. Not also for diagnosing, of course, this is also fundamental in monitoring the regression, persistence, or progression of the case later on. Also, this method of taking the endometrial sample could be done under the aid or the help of the diagnostic hysteroscopy. This should be considered to facilitate obtaining this sample, especially if the outpatient sample fails or it's insufficient or non-diagnostic. Sometimes, and I've seen that in the practice, sometimes we do the pupil biopsy, and when we send the sample to the pathology lab for histopathology, the report say that the sample is insufficient. So we need to do diagnostic hysteroscopy to take the sample under vision of the hysteroscopy. So the good thing about hysteroscopy is that you can do direct visualization of the uterine cavity and take biopsy, especially from the suspicious area where you can see thickened endometrium. You have to take biopsies. Also, sometimes you find some local lesions like a uterine polyp. This polyp should be excised because sometimes endometrial hyperplasia could be diagnosed within such a small polyp, not in the rest of the endometrial cavity. So the good thing about hysteroscopy is that you can take biopsy under vision so that you don't miss any lesion inside the endometrial cavity. Hysteroscopy, of course, is more accurate in detecting than excluding endometrial disease and has a higher accuracy for endometrial cancer than endometrial hyperplasia, because in cases of the cancer, the irregularities and the thickening of the endometrium is more obvious than the endometrial hyperplasia. Also, another diagnostic modality is the transvaginal ultrasound. Of course, the TVS or the ultrasound have a role in diagnosing endometrial hyperplasia in pre and post-menopausal women. And starting about post-menopausal women, as the TVS is more accurate in such patients or such women, because normally in the post-menopausal state, the endometrium is thin. So if we find any irregularity of the endometrial profile or abnormal double layer of the endometrial thickness, this could be also an alarming sign for cases of endometrial hyperplasia in post-menopausal women. And the cutoff value of the endometrial thickness in postmenopausal women is suggested to be as of 3 or 4 millimeters to rule out endometrial cancer. If we have endometrial thickening more than 3 or 4 millimeters, especially if the patient is symptomatic and complaining of abnormal uterine bleeding, this could be an alarming sign, and we have to diagnose this case immediately by taking endometrial sample. And by using this cutoff, the probability of cancer is reduced to less than 1% when the endometrial thickening is less than this cutoff value. So below 3 or 4 millimeters, some protocols use the 3 cutoff and some other used the 4. The guideline mentioned 3 to 4. And below this cutoff, the risk of endometrial cancer is less than 1%. But also we have to put larger cutoff values for those women taking HRT or tamoxifen. Also, some recommendations say that use this cutoff value only if the patient is symptomatic and complaining of bleeding. For example, if you are doing ultrasound for any other cause to a postmenopausal woman, she is not suffering any gynecological problem, and you find that the endometrial thickness is 5 millimeters, so no need to do any endometrial sampling because the patient is asymptomatic. But of course, this is not mentioned clearly in the guidelines, but this is according to some other guidelines like the ultrasound protocols and some ultrasound associations which put the ultrasound criteria of endometrial hyperplasia, they say that don't go for endometrial sampling except if the woman is symptomatic. Otherwise, leave her. Don't do any endometrial sampling as long as she is good and not complaining of any gynecological problem. Talking about the premenopausal woman, the problem here is that we know in the premenopausal state, it's normally to find a thickened endometrium in the follicular phase of the ovarian cycle or the proliferative phase of the endometrial cycle. So the role of ultrasound in the premenopausal state is just restricted to identify other structural abnormalities like fibroid, like adenomyosis, which may be found coincidentally in some cases with abnormal uterine bleeding, because there is overlap between the normal endometrial thickness and that caused by endometrial disease. So of course, in the postmenopausal state, the TBS will be more accurate than the premenopausal state. Also in premenopausal women, TBS should be considered for women with PCO who are suffering absent withdrawal bleeds or suffering abnormal uterine bleeding. But if you find that the thickening or the thickness of the endometrium is less than 7 millimeter in women with PCO, endometrial hyperplasia is unlikely to be present. So talking about the premenopausal women who are suffering PCOs, endometrial thickening of 7 millimeter or less, this will most likely that this case is not having hyperplasia, but more than 7 millimeters, this could be an alarming sign. So now we have two cutoffs for the postmenopausal, 3 to 4, okay? For the premenopausal, women with PCO, the cutoff will be 7 millimeter. Other modalities like CT, MRI, biomarkers have very little role in diagnosing endometrial hyperplasia. So their use is not recommended. Maybe they have a role in detecting cancer, but for endometrial hyperplasia, the role are very minimal. Some examples of such markers called the phosphate and tension homologue, the B-cell lymphoma, or the B-cell lymphoma-like protein, or abbreviated as the PAX protein, could be useful in detecting cases of endometrial hyperplasia, but more research is needed before use. So the recommendations, the final recommendations is that the use of CT, MRI, and biomarkers are with no rule or not routinely recommended for cases of endometrial hyperplasia. Clear?
Yes, sir.
Yes, sir.
Okay, great. Do you have any questions regarding the previous points before going through the main part, the management?
Yes, I have a question.
Sure.
Like in perimenopausal, you are saying the cutoff of 0.7. Aren't it was 1.2, because you are saying 0.7 millimeter at which stage? Because when the scan was done premenstrual, or it is done in the secretory phase or follicular phase, and in PCOS the cycles are prolonged.
Yes, we usually talk about the baseline, okay? The proliferative phase, not the secretory. Of course, the secretory, the endometrium will be more thick, okay? So we are talking about the baseline, okay? The baseline, which is the start of the proliferative phase. And this cutoff 7 millimeter, is just for those women with PCOS, It's just found in the studies that women with PCOS, of course, they normally sometimes they suffer from abnormal uterine bleeding, of course, due to the hormonal, derangement. Also, sometimes due to this condition, when you try to give them withdrawal bleeding, like regulating the cycle by hormone therapy or combined pills, sometimes they have absent withdrawal bleeding. So when you do the ultrasound, of course, when you find that the thickening is still less than 7 millimeter, that means that it's unlikely that they have endometrial hyperplasia. More than 7 millimeter, this could be alarming and you should do further investigations. Clear?
Yes, thank you.
Okay. You're welcome. So now let's talk about the management. And the management, we are going to divide this part into three categories. The first one is how to deal with endometrial hyperplasia without atypia, and we will take the abbreviation of EH as endometrial hyperplasia without atypia, endometrial hyperplasia with atypia, or AH, atypical hyperplasia, and the third point will be some special considerations, some associated conditions, and how to deal with them. Let's talk about the endometrial hyperplasia without atypia. What are the treatment options? For how long we are going to give the treatment, and how to do the follow-up. First of all, and as in any medical condition, the first thing you do is to talk to the woman, counsel her, tell her clearly about her condition, and that's very important in the Royal College. And that's all the guidelines are talking about the reassurance, the counseling, how to talk, and of course that's the cornerstone of part 3 MRCOG, how to deal with the patient, how to talk to the patient, of course. So the first thing is to inform the woman about the risk associated with endometrial hyperplasia. First, and that's a very important percentage, you have to counsel her and reassure her that the progression to endometrial cancer, cases with endometrial hyperplasia without atypia, the progression to endometrial cancer is less than 5% over 20 years. And most of such cases without atypia will regress spontaneously during follow-up. And if we are using or considering the complexity of the architecture in our percentage, we are going to say that the simple hyperplasia, 1% compared to 3% with complex hyperplasia without atypia. Before giving any treatment, we have first to address the risk factors, such as obesity, the use of HRT, tamoxifen. We have to modify these risk factors, avoid them if possible. This can lead to regression of the condition without even giving any treatment. If we don't find any identifiable risk factors like obesity, like the treatments, hormonal treatment, tamoxifen, we have to put in our mind the estrogen secreting ovarian tumors. We are going to search for the granulosa cell tumor by its tumor markers, the serum inhibin level and estradiol level, because granulosa cell tumors arise from the granulosa cells of the ovary. Of course, we know that granulosa cells secrete estradiol, E2, and inhibin. So the rise of such levels of inhibin and estradiol could be markers of granulosa cell tumors. So the first thing is reassurance and counseling about the risk of progression to cancer. The second thing is to address the risk factors and try to modify them if possible. Now, what are the treatment options? For endometrial hyperplasia without atypia, we have two modalities. Either observation alone without any treatment, just observation and follow up by endometrial biopsies, and the second option will be giving progestogens. Of course, treatment with progestogens will have higher disease regression rate compared with observation alone. So when you counsel the patient and give her the choices, you have also to tell her that treatment with progestogens have higher disease regression rates compared with observation alone. So if the patient accepts to take progestogen treatment, what are the types of progestogen given? We have the continuous oral route, or giving the local intrauterine or the levonorgestrel releasing intrauterine system, or the Mirena. both are effective in achieving regression of endometrial hyperplasia without atypia. So for progestogen therapy, we have two choices: the continuous oral or the levonorgestrel intrauterine system, or the Mirena. What's the better choice among these two routes? Of course, the Mirena or the intrauterine system should be the first line medical treatment. And this is a very important point in the guideline, because many scenarios, many clinical management scenarios in the exam can come and ask you about the first line treatment for cases of endometrial hyperplasia without atypia. It will be the Mirena or the levonorgestrel intrauterine system. It has disease regression rate than the oral progestogens. And of course, fewer side effects. We know that systemic progestogens have many side effects. So of course, giving the local intrauterine system will be associated with fewer adverse effects. If the patient will take continuous progestogen therapy, so the dose will be giving medroxyprogesterone 10 to 20 milligrams per day, or norelastine 10 to 15 milligrams per day for women who decline. Cyclical progestogens should not be used because they are less effective in inducing the regression of endometrial hyperplasia without atypia compared with continuous oral progestogens. So cyclical progestogens and like giving for a certain period of time and then hormone-free interval and then another cycle of progestogen and hormone-free interval. This is called the cyclical progestogen. This is less effective than giving continuous progestogen therapy. The duration of treatment should be for a minimum of 6 months. 6 months in order to induce histological regression. And if the patient is compliant, she can tolerate the levonorgestrel IOS and fertility is not desired, she should to retain the Mirena for up to 5 years to reduce the risk of relapse. The levonorgestrel is the first choice. If it's declined, then we have the oral progestogens. The minimum duration of treatment is 6 months. For the levonorgestrel intrauterine system, it's tolerable and fertility is not desired. We should encourage the woman to retain it for 5 years to reduce the risk of relapse. After that, how to follow up the patient after giving the treatment? We have to do endometrial biopsies at a minimum of 6 monthly intervals. Every 6 months, we do outpatient endometrial biopsy. And once the patient achieves 2 consecutive 6 monthly negative biopsies, she would be discharged from this follow-up program. So if the patient, especially who are on the local progestogen or the intrauterine system, if she achieves 2 consecutive negative biopsies, she could be discharged from the follow-up program. But if the patient is at higher risk of relapse, like those whose body mass index of 35 or those treated with short courses of oral progestogen, they should follow up by endometrial biopsies 6 monthly intervals for at least 2 years, and even after they achieve 2 consecutive negative biopsies, they should have annual endometrial biopsies. So the difference is that those patients who are at high risk of relapse, like those obese patients or those who was treated with short courses of oral progestogens, after achieving consecutive negative biopsies, they should have annual endometrial biopsies. Here?
Yes,
Yes.
sir.
Okay, great. So what about the management for cases of endometrial hyperplasia without atypia? Of course, hysterectomy should not be considered as a first-line treatment because, as mentioned before, most of the cases will regress even with follow-up. So there are some conditions in which we have to advise the patient to undergo hysterectomy. If the endometrial hyperplasia persists for 12 months, and this is very important, this duration, we have to know this duration very well, okay? If the endometrial hyperplasia persists for 12 months despite treatment, so the underlying risk of the cancer is high and the chances of disease regression are now low, such that hysterectomy is advised. And according to the guidelines, we have certain conditions in which hysterectomy is indicated, especially if the woman is not wishing to preserve her fertility. Progression to atypical hyperplasia, that's the first condition. No histological regression despite 12 months of treatment, as mentioned. Any relapse after completing the treatment, persistence of bleeding symptoms despite the treatment, or the woman herself declines to undergo endometrial surveillance, or she doesn't comply with the medical treatment, so it's better to advise her to undergo hysterectomy. So these are the conditions in which hysterectomy is indicated in women who not want to preserve their fertility. And if we are going to proceed for hysterectomy for those patients, in postmenopausal women, we have to offer her bilateral salpingio-oophorectomy with a total hysterectomy. And for the premenopausal woman, the decision to remove the ovaries should be individualized according to the patient wishes and according to malignancy risk factors. However, at least we have to do bilateral salpingectomy in premenopausal women, because now most of the theorists say that the precursor of most of the serous ovarian cancers come actually or originally from the fallopian tubes. So at least you have to do bilateral salpingectomy if the premenopausal woman wish to conserve her ovaries, okay? Because bilateral salpingectomy will reduce the risk of future ovarian malignancy. The approach is better to be laparoscopic than laparotomy, as it's associated with shorter hospital stay, less post-operative pain and quicker recovery, and also avoid supracervical hysterectomy, or what's called subtotal hysterectomy, leaving the cervix, should be avoided. And that's, of course, you know, now it's abundant now to leave the cervix behind, because this could predispose to, you know, stump carcinoma, and we have to eliminate all the pre-malignant tissues. So, of course, you have to remove the uterus with the cervix. Supracervical hysterectomy is not now recommended for any cause, even benign cases. And of course, endometrial ablation is not recommended for treating endometrial hyperplasia, because the endometrial destruction cannot be ensured. You can miss some endometrial tissues, and also this could lead to post-operative intrauterine adhesions, which can, you know, affect the process of endometrial sampling later on. So also endometrial ablation is not recommended. So if the patient have the conditions in which we should advise her to undergo hysterectomy, we should go for laparoscopic approach. We have to avoid supracervical hysterectomy, and also we have to avoid endometrial ablation. And also for postmenopausal women, we have to do bilateral salpingio-oophorectomy. For premenopausal women, the removal of the ovaries is individualized, but we have to do at least bilateral salpingectomy. All these recommendations of hysterectomy will be mentioned again at the same recommendations for cases of endometrial hyperplasia with atypia. I have a question in the chat room. Do we need endometrial surveillance in women who used levonorgestrel IUS? Yes, we are going to do 6 monthly endometrial biopsies also until we reach or we achieve 2 negative biopsies. After that, we discharge the patient from the follow-up program. No need to do annual follow-up like oral progestogen. So the difference between the oral progestogen and the levonorgestrel intrauterine system is that after achieving 2 consecutive negative biopsies for the Mirena, we don't need to do annual follow-up. But for oral progestogen therapy, we need to do annual follow-up unless the patient is at high risk of relapse, like very obese patient. Those patients should do annual follow-up even if they used levonorgestrel IUS. If postmenopausal, not willing for hysterectomy, can we put her on levonorgestrel? Yes, I'm saying that hysterectomy is under certain situations. For endometrial hyperplasia without atypia, the first line of therapy is levonorgestrel, whether the premenopausal or postmenopausal, okay? Hysterectomy is just for certain situations like mentioned before. If there is progress to cancer or atypical, or if there is a failure of regression, if there is continuing bleeding symptoms, or the patient is not compliant with the treatment. How long endometrial surveillance annually should be done? Forever, for life, yearly, okay? It's not for a certain period, it's of course for life. So again, to clear that point, for pre or postmenopausal endometrial hyperplasia without atypia, the first line is to give levonorgestrel IUS or oral progestogen. We don't start by hysterectomy at all, whether postmenopausal or premenopausal. But if we are going to go for surgery after the situations mentioned, if the patient is postmenopausal, do bilateral salpingiorectomy with hysterectomy. If the patient is premenopausal, do at least bilateral salpingectomy if the patient is wishing to conserve her ovaries. Clear, everyone?
Yes, sir.
Yes, sir.
Okay. Now, let's talk about the cases associated with atypia. What are the treatment options? And what about women who wish to preserve their fertility? And of course, because I asked this question, or as I addressed this point, so of course, the first thing we all are going to think about that, of course, the treatment option in cases with endometrial hyperplasia with atypia is surgical management because of the high risk of progression to cancer. So now the condition is totally different. Women with atypical hyperplasia, the first line should undergo a total hysterectomy because of the very high risk of progression to cancer. Even some cases who are diagnosed as cases of atypical hyperplasia, and after they underwent hysterectomy, after doing histopathology of the specimen, in 43% of cases, they found that there are concomitant carcinomas in such patients, you know. So sometimes you diagnose a case of atypical hyperplasia and the patient accepts to have hysterectomy, and after hysterectomy, when you do histopathological examination of that uterus in the pathology lab, you find that there are some areas of endometrial cancer within this endometrial cavity. So the risk of malignancy is very high. So the first line of treatment here is surgical total hysterectomy. And as mentioned before, for postmenopausal women, you have to do bilateral salpingiorectomy. For premenopausal, the decision to remove the ovaries should be individualized, but at least do bilateral salpingectomy. And also the laparoscopic approach is better. No need to do intraoperative frozen section analysis of the endometrium, or no need to do routine lymphadenectomy. Also avoid supracervical hysterectomy and morcellation of the uterus. Do you know the morcellation of the uterus?
No, sir.
Okay. When we do laparoscopic hysterectomy, okay?
Yes, sir.
Yes, when we do laparoscopic hysterectomy, how to remove the uterus from the abdomen? Do you know, did you see before a laparoscopic hysterectomy?
Yes, sir.
Yes, we remove the, sometimes we need to remove the uterus. Of course, we need to remove the uterus from the vagina, okay? Oh,
Yes.
yes, sometimes the uterus or the uterine size is large, so that we need to cut the uterus into two halves. This is morcellation, okay? To be easily delivered through the vagina. This is called morcellation of the uterus. It should be avoided in such cases to avoid the risk of disseminating malignant cells, okay? So let's show how much we should be careful in dealing with endometrial hyperplasia with atypia, like we are dealing with a potential case of malignancy. So again, the first line of treatment is hysterectomy, and postmenopausal will be, we are going to advise to do bilateral salpingioophorectomy, for premenopausal at least bilateral salpingectomy, and avoid the supracervical hysterectomy and morcellation of the uterus. No need for intraoperative frozen section biopsy or routine lymphadenectomy, and of course use the laparoscopic approach. That's the standard. Of course, if the patient accepts that, by this you eliminate the problem totally. But if the patient, also the endometrial ablation is the same, not recommended, as it precludes the endometrial histological surveillance. If the patient now wishes to preserve her fertility, or a pre-menopausal woman who accepts to have hysterectomy done, what we are going to do? For premenopausal women who undergo hysterectomy and bilateral salpingioophorectomy for endometrial hyperplasia, here we should offer her estrogen replacement therapy. Now she has removed her ovaries, so we have to give her estrogen replacement therapy until the natural age of menopause. And for those women who decline surgery because they are not fit for surgery or because they wish to preserve their fertility, how could we deal with such patients? First, again, we have to counsel them very well about the very high risk of underlying malignancy and the subsequent progression to endometrial cancer. And before we offer alternative choices for hysterectomy, we have to do pre-treatment investigations to rule out completely invasive endometrial cancer or coexisting ovarian cancer by doing histology, good histological specimen, imaging techniques, tumor markers to exclude any malignancy, and then offers them progestogen therapy by levonorgestrel IUS. That's the first line. If we want to give progestogen therapy, and also give oral progestogen as a second best alternative, of course, continuous oral progestogen. And once, that's very important, we are not going to give that treatment forever. Once fertility is no longer required, hysterectomy should be offered in view of the high risk of disease relapse. So that's a temporary treatment. Okay, this patient needs to preserve the fertility. She needs to get pregnant. So we are going to give her the treatment. Once fertility is no longer required, you should advise her to undergo hysterectomy. How we are going to follow up patients of endometrial hyperplasia with atypia who will go for medical treatment? Here, the intervals will be every 3 months. For without atypia will be every 6 months. Here, it will be every 3 months until 2 consecutive negative biopsies are obtained. And then we are going to do long-term follow-up in all cases every 6 to 12 months until a hysterectomy is performed. Clear?
Yes, sir.
Yes, sir.
If the fertility sparing therapy, or by another meaning the progestogen therapy, fails to induce regression of atypical hyperplasia by 12 months, at that point you have to counsel her and strongly recommend her to undergo hysterectomy. The risk of relapse is usually high in the first 2 years from diagnosis. And if the relapse occurs during follow-up, women should be advised to undergo hysterectomy as it's often associated with endometrial cancer at the final hysterectomy specimen. But if the patient declines or the surgery is not possible, you can give a further cycle of progestogen treatment that could be attempted in such cases. So if the patient declined completely to undergo hysterectomy even after relapse or after progression, or if the patient is unfit for surgery, you can try another cycle of progestogen therapy. But of course, this is very risky and the rate of progression to cancer is very high. So let's summarize now the treatment modalities for endometrial hyperplasia without atypia and with atypia. I have another question. Should the woman be pregnant after regression of the disease? Yes. And that's the special considerations we are going to talk about now after that algorithm. Okay. So to summarize, cases of endometrial hyperplasia without atypia, first thing, we have to address the risk factors. We could offer the woman observation alone or progestogen therapy. The first line will be levonorgestrel, IOS, or oral progestogen at the second line. Also, we are going to follow her by endometrial biopsies every 6 months. For atypical hyperplasia, the patient should undergo total hysterectomy and bilateral salpingo-oophorectomy if she is postmenopausal. But if fertility is required or surgery is contraindicated, you are going to follow up the same modalities. You are going to observe, give progestogen, and do endometrial biopsies, but at 3 months interval. At the endometrial biopsy follow-up, we have 3 probabilities, either regression, persistence, or progression. So what we are going to do, if there is regression, continue the levonorgestrel IOS for up to 5 years, stop oral progestogen after 6 months, and do total abdominal hysterectomy plus or minus bilateral salpingo-oophorectomy if ongoing abnormal uterine bleeding. So if the lesion regress but still there are symptoms, we can also offer total abdominal hysterectomy and bilateral salpingo-oophorectomy. But if the lesion regress and the symptoms also regress, so continue the levonorgestrel IOS for 5 years. For the oral progestogen, it's enough to stop the treatment after 6 months. But for the levonorgestrel IOS, after achieving 2 consecutive negative biopsies, we are going to discharge the patient from the follow-up program. For oral progestogen or for high-risk cases like body mass index more than 35, we are going to do annual follow-up. For atypical hyperplasia, we will continue 6 to 12 monthly follow-up for life. If under any circumstances, even after endometrial hyperplasia without atypia or atypical hyperplasia, if relapse occur at any stage, then immediately counsel the patient to have total abdominal hysterectomy. If persistence, then advise also total abdominal hysterectomy, especially if persistence after 12 months of treatment. Also, if progression means you have also to strongly recommend total hysterectomy and bilateral salpingo-oophorectomy. And if progress to cancer, then of course you have to refer to the Cancer Institute or the oncology multidisciplinary team to take actions according to the local cancer guidelines. So this is the summary of how to manage cases of endometrial hyperplasia without and with atypia. Now let's talk about certain special considerations. Before that, is everything clear? Do you have any questions regarding these points?
No, sir.
No, sir.
Okay, fine. So now the question which came now in the chat room, women wishing to conceive. So disease regression should be achieved on at least 1 endometrial sample before women attempt to conceive. And of course, we have to refer these women to a fertility specialist because here we will advise doing assisted reproductive techniques. We are not going to wait for natural conception. Assisted reproduction will be considered because it's associated with higher live birth rate, and also to avoid prolonged interval of time without progestogen treatment, which could cause the woman to relapse. So once the woman achieves one negative endometrial biopsy, you have to refer her to a fertility specialist to undergo assisted reproduction. Also, regression is very important because this will be associated with higher implantation and clinical pregnancy rates. Because if the patient got pregnant on top of endometrial hyperplasia, this can affect the implantation, of course, and even if pregnancy or implantation occur, clinical pregnancy rates could be affected. So of course, regression is very important to achieve higher implantation rate and higher clinical pregnancy rates. And also obese women should aim for a body mass index of less than 30. This will aid and increase the chances of success of assisted reproductive techniques, because you know that also the obesity will affect the fertility potentials. So of course, while having the medical treatment by progestogen, she should also aim to reduce her body mass index to less than 30. And once fertility is no longer required after she got pregnant and delivered, hysterectomy should be recommended to women with atypical endometrial hyperplasia once fertility is no longer required because of the high relapse rate of the disease and the potential for disease progression. But of course, if she's just complaining of endometrial hyperplasia or having endometrial hyperplasia without atypia, she could undergo further follow-up after delivery. But hysterectomy should be recommended to women with atypical endometrial hyperplasia. That's the first consideration or first condition, those women who wish to conceive. What about HRT and endometrial hyperplasia? As a rule, we don't recommend giving estrogen only HRT to any woman with a uterus. So any woman who have menopausal symptoms, who want to take HRT and she is not hysterectomized, you should give her combined hormone replacement therapy, estrogen and progesterone. Giving estrogen alone unopposed by progestogen will increase the risk of endometrial hyperplasia. And also, all women taking HRT should be encouraged to report any unscheduled vaginal bleeding promptly and immediately. The unopposed estrogen replacement therapy increased the risk of endometrial hyperplasia, and you have to add progestogen of a minimum of 1 milligram per day norepinephrine or 1.5 milligram per day medroxyprogesterone to the unopposed estrogen replacement to reduce the risk of endometrial hyperplasia. So these are general rules when giving HRT to a woman with a uterus to treat menopausal symptoms. Don't give estrogen alone. If a woman with endometrial hyperplasia taking sequential HRT preparation who wish to continue on HRT should be advised to change to continuous progestogen intake using the levonorgestrel or continuous combined HRT preparation. Some women, especially in the perimenopausal period, they suffer from some menopausal symptoms like the hot flushes, like the night sweats, like the mood changes, but they still have menstruation. So sometimes they take sequential HRT preparation, like taking estrogen at the proliferative phase of the cycle, and then at the luteal phase or at the secretory phase, they take progestogen and then hormone-free interval for time of menstruation. So they take estrogen all over the cycle, and just taking progestogen at the secretory phase. And after that, they have hormone-free interval for having menstruation or cycles. Okay? If they develop endometrial hyperplasia, they should be advised to shift from this sequential pattern to continuous combined as estrogen and progestogen all over the cycle, or to have levonorgestrel intrauterine system. Okay? Also, women with endometrial hyperplasia who already taking a continuous combined preparation, so they are taking continuous combined preparation from the start and they develop endometrial hyperplasia, at that point we have to address or review their need to continue the HRT. By another meaning, if there is a possibility to stop the HRT, so they should stop HRT. So if the patient develop endometrial hyperplasia and she's taking sequential HRT, you have to shift her to continuous HRT or giving her levonorgestrel intrauterine system. But if she is already on continuous combined preparation and she develop endometrial hyperplasia, at that point, you have to review her need of HRT. And if it's possible to stop the HRT, you should advise her to stop HRT. Women on adjuvant treatment for breast cancer, that's the third condition we have, or the third consideration we have. We know that tamoxifen, which is a selective estrogen receptor modulator, is used extensively as an adjuvant treatment for breast cancer cases. And the problem with tamoxifen is that it's associated with a very high risk of developing endometrial hyperplasia and endometrial cancer. As I said at the start of the session, it's a selective estrogen receptor modulator, which have an antagonist effect on the estrogen receptor of the breast, but on the same time have an agonist effect on other tissues, including the vagina and the uterus, which can lead to developing endometrial polyps, hyperplasia, and increase the risk of endometrial cancer. And of course, the risk increases with both dose and duration of treatment. So, if the patient develop endometrial hyperplasia with tamoxifen, she should shift for another forms of adjuvant therapy for breast cancers, like the aromatase inhibitors. And also, there are some evidence that levonorgestrel intrauterine system could be given or could be offered for those women taking tamoxifen to reduce the risk of endometrial hyperplasia. But the problem with levonorgestrel IUS in such cases is that we don't have good evidence about its effect on the breast cancer. We don't know whether these very small amounts of progestogen coming from the levonorgestrel which enter the circulation, do they have any adverse effect on the breast cancer recurrence rate or so? We don't have a good evidence, so we cannot recommend that. So if the woman develop endometrial hyperplasia on top of tamoxifen, okay, we should review the need for tamoxifen. If it could be stopped, then it's okay. If not, we could change to another form of medicines or to deal with the case according to the type of endometrial hyperplasia. For example, if the patient is in very need of tamoxifen and she cannot stop it, we can offer her, for example, hysterectomy to eliminate the problem of endometrial hyperplasia, and she can then take tamoxifen freely, of course, especially if her fertility is no more desired. The other category of drugs like the aromatase inhibitors, like the anastrozole, the letrozole, these aromatase inhibitors, they inhibit estrogen synthesis in the peripheral tissues by inhibiting the aromatase enzyme. So they could be used as an alternative for tamoxifen, and they don't have any effect or agonistic effect on the endometrium, so they are not known to be associated with increased risk of endometrial hyperplasia and endometrial cancer. Clear, everyone?
Yes, sir.
Yes, sir. Yes, sir.
So the last condition or consideration here, the endometrial hyperplasia confined to an endometrial polyp. At this point, we have to excise this polyp completely and then deal with the condition according to the histological classification of. Of course, also we have to take samples from the background endometrium. So when you do, for example, hysteroscopy and you find an endometrial polyp, you don't only remove the polyp and leave the other endometrial cavity. No, you have also to take random samples from the background endometrium, and then according to the type of endometrial hyperplasia, we are going to match. So this is collectively the most important points in dealing with endometrial hyperplasia. This is a very important topic, and it's considered one of the basic gynecological topics. So some questions come at the level of part 1 MRCOG, and as mentioned before, we have to increase our clinical background even at the level of MRCOG part 1 exam. Is there any difficulties? I have a question. Is there any difficulties for endometrial biopsy in women with levonorgestrel intrauterine cycle? No, we can take the biopsy while the levonorgestrel is in situ, no problem at all. Okay, especially in most times we use the people biopsy. It's a very, very thin instrument. You know, we can do it outpatient, inserting it very carefully in the endometrial cavity, taking the biopsy, and of course analyze that specimen. And no need to remove the levonorgestrel in each time, of course, of biopsy. Of course, it's retained in situ, and just we take the biopsy, no problem at all. Is there any question?
No, sir.
Okay. So before we end the session, let's practice few questions. Let's think about such questions. A 46-year-old woman complains of menorrhagia. She is diagnosed to have endometrial hyperplasia without atypia. The risk of her disease progressing to endometrial cancer is?
C.
C, sir.
Yes, that's right.
It's C.
Less than 5% over 20 years. So the right answer is C.
C, okay.
An endometrial people biopsy result that you have performed a week ago has shown endometrial hyperplasia with atypia. The patient is 55-year-old, para 0, who has a previous history of breast cancer. When counseling the patient, what would be the chance of her also having a concomitant endometrial cancer if a hysterectomy is performed in the next few weeks?
The real one is 43%, but I choose E.
Yes.
I choose D.
Yes, of course.
I think E 40.
E.
Yes, it's 40%. Of course, in the guidelines, it's 43, but of course, in the exam, you choose the best answer. So it's 40 or around 40%. That's right. So the answer is E. A 49-year-old woman has had a people biopsy done for a normal heavy uterine bleeding. The result shows endometrial hyperplasia without atypia. What is the most appropriate management for her condition?
B.
B.
Yes, exactly. Levonorgestrel intrauterine system. Exactly. A 46-year-old woman attends the gynecology clinic 6 months after being diagnosed with endometrial hyperplasia without atypia. She is on norethindrone 15 milligrams daily. She has had a surveillance people biopsy. The result shows a persistence of the same endometrial pathology. What will be your further management?
D. Of hysterectomy.
D of
A.
A. D over hysterectomy.
D. Of hysterectomy.
Final answer?
Yeah.
A.
Yes, sir.
I don't agree with you. No, look at the scenario. Okay, we have two important points. She is 6 months after being diagnosed. Okay, so she took the treatment 6 months only. Okay,
Yeah.
and he said that the sample persists. No progression, just persistence of the same pathology.
Yeah. I
We have
choose
mentioned,
A.
we have mentioned that when persistence for 12 months, okay, at that
Yeah.
point, okay, we then offer hysterectomy, okay? She just took the treatment for only 6 months, so you can continue for further 6 months and then another biopsy. At that other biopsy or the second biopsy, if still persists, at that point we can offer hysterectomy.
Hysterectomy.
Okay,
Yeah.
clear?
Clear, sir?
Okay,
Yes, sir.
fine. Okay, the last question. A 55-year-old woman attends the gynecology clinic with postmenopausal bleeding. She had a transvaginal scan which showed an endometrial thickness of 8 mm. She had a successful people biopsy in the clinic. The result shows endometrial hyperplasia with atypia. What is the most appropriate management?
D.
Yeah. B.
B.
B, sir. B.
B.
It's a
Yes,
why
exactly.
B? D.
Yes, B, the second option. Postmenopausal, so we went atypical hyperplasia, so we are going to do or to offer total abdominal hysterectomy and bilateral salpingioophorectomy. Of course, the laparoscopic approach is better. No need to do pelvic node sampling. So of course, the option is B, laparoscopy, total hysterectomy and bilateral salpingioophorectomy. So by this, we come to the end of the session, but wait until Mafia now will talk about some gift from mid-exam for the attendees of this webinar. And also she are going to talk to you about the services given by mid-exam. But before I leave you with her, if you have any question, please ask me. It's my pleasure to answer you. About
Thank
these,
you so much.
anything related to the MRCOG Part 1 exam.
Thank you for your precious lecture, sir.
Thank you so much. You are most welcome.
Okay, so hello everyone. Hope you all are safe and well, doing best in passing your exams. This is Mafia, the course coordinator in the Med Exam Expert. So first of all, your presence shows that you really want to pass your exams. But here the questions arises that how? How is the questions that how you gonna pass your exams? How we can trust an organization? How can you trust an organization? How can we pay our precious earning to the right organization, whether it's worth it or not? Here comes the answer to all your queries. This are the very talented, very hardworking student, Amrita, who got 80% marks under the supervision of Dr. Helmy and Dr. Zaib Qureshi. And then we have a very talented student, Madhu, who is still running a course in MRCOG too. So the next is Farjana. She is also a student in MRCOG Part 2. Well, here is the very important question that what to study. I know your syllabus is too much, but what is to be selected for the proper preparation of exam is really matter. But don't you have to worry. Definitely Dr. Helmy will help you out in this. Isn't it so, Dr. Helmy?
Sure, of course, Mafia.
Yeah. So here goes our course, which is starting from 14th of October 2020. And Now comes our course mentors. Dr. Helmy is well aware of, you all are well aware of Dr. Helmy and Dr. Zaib Qureshi, who is really exceptional. Then we have the course feature. First of all, our live sessions. There will be the live session where you can interact with your mentors who can actively participate in helping you and solving your queries. You can even participate yourself for learning new things. Then we are providing you with the topic test where you can test yourself whether you are what you have learned from these sessions. You can measure your progress and that's what you have learned. Then we have exams, which are the mock exams, which are incredibly beneficial for you guys. What you have to do, you can practice your exam on our website, which is give you a real exam like environment. You can even test that before joining our session. Let's say then we have a session recording. We know that you are super busy with your schedules. So in case if you have missed any live session, you can watch later its recording on our website. Then we have study groups where you can share all of your queries with your mentors, with your study partner, and whatever you have a query, you can discuss there. Now here comes a gift. So the gift is for all of you, there is a 60% discount. Sorry, $60 discount. This is only for those students who have joined our webinar. So don't forget to use this coupon, which is SDM51. What you have to do, this is now, I'll tell you how you can register a course. This is for only those students who are interested in buying a course. First of all, what you have to do is you have to go to our website, which is mathexamexpert.com, and then you have to click on sign up button. Then after creating your account on our website, you have to click on this course catalog. While clicking on this, you will go to this dashboard and you have to select the course which you want to choose. After that, what you have to do is you have to click on this get this course. Then what this dashboard will show you that you can now enter your coupon and get $60 discount. You have to write coupon over here, then you will able to get the course. So thank you so very much. As you know that successful people ask more questions. So if you have any query in your mind, you can directly ask any one of you. Okay,
Thank you, Mafia, for your presentation. Of course, any of you of our colleagues who want to ask her about anything regarding the course, of course, we are listening to your questions.
Okay, thank you, Dr. Helmy.